get somebody at Mayo. I'll get someone at Mayo who needs to be seen in South Carolina, and it's kind of nice to know that we've got people all over who are able to help patients with these wonderful lenses. I'm also delighted to see that many of you are already members of the Scleral Lens Education Society, and I would encourage you on behalf of the entire Board of Directors, Mindy especially, to consider fellowship in the Society. It's a relatively simple process of writing a couple of case reports, and we would be more than happy to walk you through that process too. So let's get started with tonight's presentation. I don't have any personal financial relationships with any of the companies that were listed. Thank them very much for supporting the Scleral Lens Education Society. I'm also not going to be talking about any off-label uses of scleral lenses. So during the next couple of minutes here, we're going to be doing a couple of things. First of all, I'm going to describe scleral lenses, although if you are already a member, you probably know quite a bit about them already. We're going to define some fitting characteristics of scleral lenses, identify how scleral lenses can be used in current contact lens practice, and review some cases in which we've used scleral lenses in our practice. Just to give you a little bit of background personally, I had the opportunity, along with two of my colleagues from Mayo's Cornea Service, to travel to England to attend one of Ken Pullum's workshops in January of 2006. So we here at Mayo began on the large side of things. If you've been following scleral lens literature at all, you realize that European lenses tend to start at 25 millimeters and go down. In the United States, we've kind of gone the other way. We've started at intralimbal lenses and gone up. So a little bit of a different perspective. I tend to fit rather larger lenses. We actually initiated Mayo Clinic's scleral lens practice in June of 2006. We are a referral-based practice, and that means that by the time patients get to me, they have generally run out of other options. They've already tried corneal and corneoscleral lenses. They may have tried piggyback lenses or hybrids, and I'm usually their last stop before a transplant or tarsorrhaphy or other more invasive procedure. So my practice population might be just a little bit different than some of yours. Like I mentioned earlier, we began the program here in June of 2006, and as of last month, we had evaluated 345 patients for scleral lens wear. Some of these patients decided after the evaluation, or perhaps during the evaluation, that this was not something that they wanted to pursue, and so we only did the initial evaluation of 115 of those patients. Of the remaining patients who actually initiated the scleral lens fit, 44 patients abandoned the fitting process for one reason or another. We've actually completed the fit in 172 patients, or 264 eyes as of yet, and a number of patients are still in the fitting process. So I always think it's a good idea to be very clear about terminology, and it would certainly behoove those of us who work with scleral lenses to agree upon definitions, both to clarify things for our patients and to allow us to have conversations with each other that make sense. These definitions that I'm going to present are by no means carved in stone. Terminology is certainly evolving. A number of people prefer to define lenses based upon the overall diameter of the lens. I personally prefer to use a more functional definition because each of the lens categories that we're going to talk about has particular indications and fitting characteristics. And size doesn't necessarily matter quite as much as how that lens is supported by the front surface of the eye. So the way I define a corneal lens is a lens that is entirely supported by the cornea and it does not extend beyond the limbus. I use the term corneoscleral lens to describe lenses that are supported by both corneal and scleral tissue. They do extend beyond the limbus, but derive a fair amount of support from the corneal tissue as well. I tend to reserve the term scleral lenses to talk about large diameter lenses, generally 18.0 millimeters or larger. They are supported entirely by scleral tissue, and they completely vault the cornea and limbus. And I don't make this definitional these definitions to exclude corneoscleral lenses from the consideration of the Scleral Lens Education Society. It's just that my personal experience has been with the larger diameter lenses. So scleral lenses are unique in that they actually don't contact the cornea, so I sometimes joke that we should call them non-contact lenses. Every other type of lens derives at least some support from corneal tissues, but scleral lenses don't. And this distinguishing characteristic leads to a fitting paradigm that's quite different from the way that most of us were originally taught to fit rigid lenses. This is a diagram that the artists at Mayo came up with for me of the ideal scleral lens fit. And honestly, the only time I've seen a fit like that, or the only time that I can imagine seeing a fit that would be quite that perfect, would be if a patient was lying down with their lids removed, because it never sends quite that well, and there's usually not quite that even a fluid reservoir behind the lens, but it gives you a general idea as to how the lens fits. It is supported entirely by scleral tissue, and it rests above the cornea, so you trap a layer of fluid between the cornea and the posterior surface of the lens. So my fitting goals are a scleral seal with evenly distributed bearing. Like I said, I've primarily used lenses that are 18 millimeters or larger, and I have never ordered a fenestrated lens, although I know a number of my colleagues do like to use fenestrations. Dr. Perry Rosenthal, the gentleman who developed the Boston ocular surface prosthesis, very frequently speaks of a fluid ventilated lens. Ken Pullum refers to scleral lenses as fitting with a scleral seal. Basically, I want to maintain a chamber behind the lens that's completely fluid filled. And fenestrations, in my mind anyway, may allow for the introduction of air bubbles into the chamber. This could lead to corneal desiccation, which I certainly don't want in these lenses. I like to have the lenses clear the limbal area entirely. The limbus is an important area of the cornea that we don't probably fully understand. My goal is to avoid any mechanical challenge to that tissue as much as I possibly can. Apical clearance is another defining characteristic of scleral lenses. It's not always as perfectly demonstrated as the diagram shown earlier. If the lenses are large, or if the upper lid tension is great compared to the lower lid tension, as is in the case in cranial nerve 7 disorders frequently, the lens may decenter inferiorly. But in general, I haven't noticed any complications if the fit features a small area of feather touch in the superior quadrant. The conjunctival tissue overlying the sclera isn't completely regular, so you get some fluid exchange just due to that regularity. Tears may also be exchanged through a diaphragm-like action. When the patient blinks, the upper lid forces the lens closer to the eye. When the patient opens their eye, fluid is drawn back underneath that lens as it resumes a more normal shape. This is a picture of one of my scleral lens patients demonstrating what I think is a pretty good fit. You'll notice a relatively even scleral alignment, although at the 10 to 11 o'clock area you do notice a little bit more fluorescein underneath the haptic or flange than you do at 7 or 8 o'clock. There is a little bit of edge lift, and the cornea is completely cleared. So why would anybody want to use a scleral lens? Well, they're the only lenses that completely clear the corneal surface. Ideally, scleral lenses aren't going to touch the corneal epithelium, so in cases of significant irregularity, we don't have to try to balance the lens over peaks and valleys of a highly irregular cornea. We simply construct a dome over the area of irregularity. The other advantage of a scleral lens is that if you have an epithelium that is somewhat fragile, you may be able to avoid damage to that tissue with a scleral lens. Another reason to use scleral lenses is that you're distributing the bearing of the lens over a larger area. I have a daughter who is currently going through pre-algebra and doing some geometry, and so I remember pi r squared, and I did some math here and discovered that if I have a 15 millimeter lens with a 2 millimeter flange, the bearing is distributed over a 44 square millimeter area. On the other hand, if I have an 18.2 millimeter lens with a 2 millimeter flange, the bearing is distributed over 102 square millimeters, so a big difference in the amount of surface area that bears the burden of supporting that lens. If you don't like math, this may make more sense to you. Now, Chris Sint actually gave me this particular analogy. We both live in northern climates. If you live in California or if you live in a southern climate, you may not know what I'm talking about here, but the picture on the left is, of course, a stiletto shoe. The picture on the right represents snowshoes, and I can tell you from personal experience that it's a whole lot easier to walk across a frozen lake with snowshoes than it is to walk across a lake with stiletto heels, and the same principle applies here as applies with scleral lenses. If you can spread that bearing over a large area, you're going to be more comfortable. A lot of patients report that scleral lenses are a little bit more comfortable than corneal lenses, and the reason for that is as follows. Cornea is relatively densely innervated compared to conjunctival tissue. So scleral lenses landing beyond the cornea are landing on conjunctiva, which is relatively less densely innervated. Scleral lenses also tend to move very little, and as we all know, patients tend to be more comfortable with lenses that are not quite as mobile. And scleral lenses also offer improved stability compared to corneal RGPs. This patient is wearing a scleral lens. Upper and lower lids are retracted. You can see that we are not going to have an awful lot of possibility of the lens popping out with a blink or popping out with quick eye movement because the lens is tucked back behind the lids. We also know that corneal lenses tend to center over the steepest area covered. In the case of scleral lenses, the entire cornea is usually steeper than the landing zone, so the lenses tend to center reasonably well. One caveat here is that the upper lid tension and lower lid laxity can sometimes cause the lens to decenter a little bit inferiorly. So why would you not use scleral lenses? Well, first of all, there is potentially some decreased oxygen availability. Rigid gas permeable lens materials made scleral lenses possible compared to PMMA, but oxygen transmissibility is limited by lens thickness. In general, scleral lenses can be anywhere from 0.35 to 0.5 or even millimeters thick or even thicker. So the oxygen transmissibility through the lens itself goes down in a linear relationship as the thickness goes up. Lack of movement can also create a relatively static fluid reservoir behind the lens that is not a problem with corneal lenses. Patients can get a little apprehensive. These lenses are darn big. We've got a couple of pictures here that show the size of a scleral lens compared to the size of a normal corneal lens. And some patients are intimidated by the prospect of placing the lens on the front surface of the eye face down. We can sometimes cause even more apprehension by using some rather unfortunate terminology. We tend to tell patients that we're going to insert the lens into their eyes. Now, patients think of the dictionary definition on this, and the dictionary definition of insert is to put or place inside. I prefer to use the term apply scleral lenses. Patients haven't talked or haven't objected too strongly to that one just yet. And then there's eye care provider apprehension. There's certainly the idea that not all patients need scleral lenses, and I would concur with that 150%. We have lots of other options that could very well provide perfectly adequate vision comfort and a good physiological response with any number of cornea or corneoscleral options. However, I'd argue that we shouldn't be shy to use scleral lenses when it is appropriate. There's certainly a perception that scleral lenses and fitting scleral lenses takes an inordinate amount of time, and it certainly can because most fitting at this stage in any case is done diagnostically. But I've found that it's really not a whole lot more complex than fitting other specialty designs. The picture down and to your right down here shows kind of the position that I have to get into in order to get the scleral lenses onto a patient's eye at times. You do have to stand in your head. You have to be a little bit of a contortionist in order to apply these lenses initially, although I must say I'm getting better at that as time goes on. But I think perhaps one of the larger issues is that we just don't know what's happening out there beneath that scleral haptic. We're a little uncomfortable once we get beyond the limbus.
Excuse me, Muriel.
Yes.
If you tried to select your pointer just then, I didn't see it, so I'm not sure you had actually selected the pointer.
Oh, okay. I've got the pointer showing up on my screen here. Is it
your mouse's pointer, or did you select the little hand?
I selected it's a star, a wand with a star on it.
Okay, sorry, maybe I'm just not seeing it here.
Is anybody else seeing a pointer? Okay. Well, I'll just continue. And if you see a pointer, great. If not, I'm not going to do anything too terribly unusual here. The radical truth about scleral lenses is that base curve is minimally important, and I feel like a heretic as I say that, because we've all been taught that base curve is how you fit a rigid lens. It's our trademark. It's our currency. It's certainly within our comfort zone. But since we're not going to try to align the back of the lens with the front of the eye, base curve really doesn't matter. The next radically different idea is that keratometry really doesn't help an awful lot, because it's only going to give us information on the very central curvature of the cornea. Now, topography gives us some idea of peripheral corneal contour, but it doesn't tell us much about the sclera or about how scleral lenses are fitting. Anterior segment OCT certainly holds promise for evaluation of scleral contour, but this technology is still relatively expensive. Here at Mayo, we don't have access to the technology. Although, looking at pictures of other folks who present on scleral lenses, I would love to get some of those cool pictures, but I don't have the technology available. And it would also be unfortunate if scleral lenses couldn't be made available to patients who could benefit from them because of a lack of access to an anterior segment OCT. Ace Vanderwerf is working on doing some evaluation of scleral contour, but right now we don't have an easy way to assess the shape of the sclera in practice. So the easiest way to do these is just to put a lens on the eye. So what does it look like? Well, kind of like this. The currently commercially available scleral lens designs in the United States are largely defined by base curve, but not all scleral lens designs use base curve as the defining characteristic. For instance, Ken Pullum's lenses from Innovative Sclerals are identified by a number, 1 through 14, and an increasing number corresponds to a defined increase in sagittal depth. The BOSS, for Boston Ocular Surface Prosthesis, is also not defined by base curve. Depth is controlled there by varying the angle and the width of the spline, which roughly corresponds to our transitional area. I've been fitting Jupiter lenses, and these lenses are, in fact, identified by base curve. So I found it helpful to think like a roofer. It's all about the rise and the run. The rise would be equivalent to the radius of curvature. The run is equivalent to the peripheral curve radius. If you want to increase the depth, you either decrease the radius of curvature and make it steeper, or you increase the radius of a relatively steeper curve while maintaining the overall diameter of the lens. The basic Jupiter design is as follows. In an 18.2 millimeter lens, you've got an optic zone of 8.2 millimeters. The base curve plus 0.4 millimeters is the first peripheral curve. The first peripheral curve width is 2 millimeters. The last three measurements are standard for all of these lenses. You've got 9.0 millimeter curve for 1.0 millimeters, 12 1/4 for 1.5 millimeters, and 1450 for 0.5 millimeter. Jupiter lenses are also available in larger or smaller diameters, and they can be very easily customized. You can really change any of the base curves, or I'm sorry, any of the peripheral curves. You can change the radius of curvature on anything, and the wonderful thing about them is that they come with fitting sets. So as I mentioned before, easiest way to fit a scleral lens is to put a lens on an eye and take a look at it. So what are some of the indications that have been reported for scleral lenses? Well, the most common indication is corneal irregularity, and this can be either primary corneal ectasia, including things like keratoconus or pellucid, or Tyrion's marginal degeneration, or post-surgical irregularity. I actually have a relatively large number of patients who have had refractive surgery in my practice. Penetrating keratoplasty patients may also need scleral lenses. Some of my patients have had excision of Salzmann's nodules and end up with scleral lenses following that surgical procedure. Ocular surface disorders can be very nicely treated with scleral lenses. Dry eye syndrome, either undifferentiated dry eye syndrome or a specific condition such as Sjogren's syndrome or graft versus host disease, can respond very nicely to scleral lens treatment. Epitheliopathy, including neurotrophic keratopathy or exposure keratopathy, can also be treated well with sclerals. I have had not terrific success fitting patients with high refractive error with scleral lenses, but that could be due to the fact that I'm using primarily the larger diameter lenses rather than corneoscleral lenses. Corneoscleral lenses may be very successful in a population of patients without eye disease, but with high refractive error that can't be comfortable in any other type of lens. So let's talk about a few cases here. Case number 1 is a 46-year-old female. She has a developmental disability, insulin-dependent diabetes, and asthma, and her spectacle correction, which I think was probably obtained by a guess, was a minus 1250 in the right eye, minus 875 with some SIL in the left eye, but she was not seeing particularly well with that correction. So we put some diagnostic lenses on her. I used the Jupiter K8 design to get a little extra depth because she had a very steep cone. Found an over-refraction of approximately minus 18, and that let her count fingers at 10 feet. When I let her match Leah symbols at 14 inches, she was able to resolve 20/60. So we ordered a Jupiter lens. Now, some of you who paid attention in optics class are looking at that going, oh, you didn't order the right power. You should have ordered a different power to make up for vertex conversion. When I find a high power over-refraction, I'll take the patient out of the phoropter and I'll intentionally hold trial lenses as close as I possibly can to the surface of the scleral lens to reduce variability in vertex distance. I found that a trial lens over-refraction can be really helpful to demonstrate to patients what vision could potentially be through the lenses as well. And so I will routinely use them, and I can get them a little closer than I can get the phoropter. So this is what the lens looked like on her eye. You may recognize this picture from earlier, but you'll see that we've got a nice zone of scleral alignment. There is not a lot of vascular impingement at any point beneath that scleral flange. The cornea is covered with a fluid layer that is dyed bright green, and the post-lens fluid reservoir, if you compare it to the thickness of the cornea or the thickness of the lens, is roughly 0.2 to 0.3 millimeters. I assume that my lens is going to be about a 0.3 to 0.4 millimeter thickness, and I assume that a cornea is going to be about a 0.5 millimeter thickness. So that gives me sort of a way to estimate how thick that post-lens fluid reservoir might be. Again, here's a picture of the lens on our eye, and you'll notice that we've got some nice scleral alignment here without significant vascular impingement. You see those vessels going up underneath the lens, and they just keep coursing right on through. Plenty of clearance in the limbal area. I'm not going to challenge those cells with this. There is, however, a slight variability in edge lift between this position at about 10 o'clock and this position at about 7 o'clock. That's not uncommon at all. In fact, the Visser practice in the Netherlands very frequently prescribes scleral lenses with toric peripheral curves in order to alleviate any impingement that may happen in those flatter areas. So the outcome for this patient was really quite gratifying. The patient's caregiver reported that the patient navigated much more confidently. The patient wasn't able to apply and remove the lens by herself, but had a very devoted caregiver who was able to do that for her. Distance visual acuity, at 5 feet she was making out the 12.5 Leah symbols, matching. she was functioning pretty comfortably, and the fact that she gave me a big, huge hug every time she left or came into the office led me to think that we had done something positive for her. Case number 2 is a 74-year-old female who had some exposure keratopathy in the right eye due to canthal malposition following radiation therapy for an adenoid cystic carcinoma. And this is what her cornea looked like when she came in. She had had long-standing exposure keratopathy. You'll see several fronds of new blood vessels growing into the inferior cornea, along with significant irregularity there. You see to the right of the screen a band of tissue that was a leftover from a previous tarsorrhaphy that connected the upper and the lower lids. And this was patient number 2 that I ever fitted, and I looked at that band and thought, how on earth am I going to get a lens in there? But the patient was very easy to work with and worked with me well on this, and we managed to do it. So her visual acuity at presentation was about 2100 with minimal refractive error. Keratometry readings were pretty flat, so we put a Jupiter 18.2 standard design lens on her with a pretty flat base curve. And with the diagnostic lens and the appropriate over-refraction, she was actually capable of 20/25 visual acuity. It's pretty exciting for her. This is a picture of the malposition of the nasal canthus, and you can get a clue as to what the scleral lens looked like behind there. Now, this is one of those cases where the lower lid is not very taut and the upper lid is relatively heavy, pushing down on the lens. So this lens did decenter inferiorly, as is obvious by this. Now, in this case, her upper lid was obviously being held. But this lens did decenter inferiorly, didn't cause any problems in the superior cornea, thankfully, so we were grateful for that. Another thing that happened with this inferior decentration was a base-down prismatic effect in the right eye. So we actually ended up incorporating some base-up prism into her spectacles that she wore over top of the contact lens. Here's one more picture of that lens on the eye. She actually did very well with this lens. The ocular surface was maintained. She wasn't wearing it all day, every day. She would wear it for 4 to 6 hours a day, and that seemed to be enough to keep the surface intact. She eventually developed a neurotrophic ulcer in her left eye and was fitted with a scleral lens in her left eye as well. The third case is a 36-year-old male, high myopia, had been wearing traditional hydrogel, hema-based hydrogel lenses as daily wear lenses only, and had a 1-year history of waxing and waning, redness and irritation, blurred vision. When he came to us, he looked kind of like this. Best corrected vision was 2400 in the right eye. Best corrected vision was 2050 in the left eye. And this had all the clinical earmarks of limbal stem cell deficiency, although we didn't confirm the diagnosis with impression cytology. But you can see conjunctivalization of the cornea. You can see those whorl-like grayish epithelial sheets moving into the center of the cornea. You can see significant neovascularization, particularly in that right eye. Left eye corneal epithelium was certainly irregular to the point where he was only getting 20/50 vision, but left eye was not nearly as involved as the right eye. When I saw this patient initially, I looked at that right eye and said, I really don't want to put a lens on that. So I gave Dr. Leo McGuire a call and said, are you sure you want me to put a lens on this eye? And he said, well, yeah, it's the only thing that's going to clear it up. So we did. And when I took a look at the lenses on his eye, you'll notice that I made a little alteration in the lenses that I ordered for him. Instead of a 4.5 millimeters, I ordered a 15.0 final curve. I wanted to flatten that out a little bit because the 14.5 was impinging just a little bit on that on the conjunctival tissue on the very edge of the lens. So he got the lenses. he wore them for about 2 weeks and came back looking like this. Right eye doesn't look a whole lot better, but he was certainly seeing a whole lot better through that right eye. 20/40 visual acuity there. And in the left eye, he was actually achieving 20/25 just 2 weeks after starting scleral lens wear. He came back about 9 months later and was seeing 20/25 minus a couple in the right eye. You'll notice he has a little bit of residual scarring there. And 20/20 in the left eye. Now, he's kind of an interesting patient because he decided that he really didn't want to wear lenses. He'd much rather wear glasses because lenses were kind of a pain. And so he asked if he could discontinue scleral lens wear. And with fear and trepidation, Dr. McGuire and I gave him leave to do so. He maintained a perfectly clear cornea and excellent visual acuity for about 18 months. Then his condition recurred. We put him back in scleral lenses for about 3 weeks, and following that 3-week period of limbal stem cell protection, he discontinued scleral lens wear once again and is back to wearing glasses. So this patient was interesting. It got me thinking about limbal stem cell deficiency perhaps a little bit differently than I had before. The fact that he improved so rapidly with scleral lenses and the fact that he maintained corneal clarity for 18 months without any scleral lens wear led me to think that perhaps limbal stem cell deficiency was actually limbal stem cell dysfunction. Sometimes those cells may need only a protected environment in order to heal and maintain corneal clarity. So that was the fun thing about that particular patient. Going on to case number 4, this is a 74-year-old female with a 4-year history of pain, inflammation due to ocular cicatricial pemphigoid. She was on maximal systemic and topical medical therapy. She had persistent epithelial defects in both eyes. Left eye was significantly scarred and vascularized, and so we were doing everything we could to maintain vision in her right eye. So at presentation, she was about 2100 in her right eye, approximately hand motion at several feet in her left eye. We couldn't get Ks. Trichiasis with symblepharon formation was present in both eyes, and both eyes had significant epithelial defects. Left eyes was much worse than the right eyes. So we put some scleral lenses on her. Due to the due to the symblepharon, we weren't able to get good centration with an 18.2 millimeter lens. So the diagnostic lens showed in the right eye, showed complete corneal clearance with some peripheral blanching as well as significant temporal decentration. So we stole 0.2 millimeters from that first peripheral curve, made it a 17.8 rather than an 18.2 lens. At the initial scleral evaluation, we were able to help her achieve 20/70 visual acuity with the proper over-refraction over the lens. In the left eye, we tried a couple of diagnostic lenses, all of which had large central bubbles until we reached about a 43.25, which is a 7.8 millimeter lens. There was still quite a bit of clearance in the mid-periphery, however, and reasonable conjunctival alignment. So the change we made in that lens was to take the first peripheral curve from an 8.2, which it would have been in a standard design, down to an 8.0, and just see if we could get a little bit better alignment with that. And indeed we did. This is what the right eye looked like at the 2-week follow-up point. She was actually, much to our delight, capable of resolving about 20/50 at that 2-week follow-up. So nice healing of the epithelial defect. Epithelium is a bit irregular, but there was no frank defect after just 2 weeks of lens wear. The left eye epithelial defect had gotten considerably better, but this eye was not going to see particularly well no matter what we did. So our goal there was to simply maintain the ocular surface as best we could, maintain comfort as best we could. So outcome with this patient was that her visual acuity improved to 20/50 in her right eye with no improvement, unfortunately, in the left eye. She is the only patient in my practice who wears lenses continuously. She takes them out 3 or 4 times a day in order to instill her topical medications and to clean and disinfect the lenses, but does sleep while she's wearing the lenses. She just takes them out first thing in the morning, cleans them up, puts in her medication, has them out a couple times during the day, and then takes them out right before bed, cleans them up, refills them with fresh saline, and then reapplies them. Her corneal surface has been maintained over 3 years, and her visual acuity has been maintained over that period of time as well. So I lose a little sleep over this one because she is sleeping in the lenses, but I think the alternative to sleeping in lenses in her case would be continued corneal erosions. Case number 5 is one of my cases of graft versus host disease. I always feel bad for these patients. They've been through so much by the time they get to me. First of all, they've had cancer, and then they've had some sort of a bone marrow transplant, which is no picnic. And just when they think that they're out of the woods, their eyes start to hurt. This 35-year-old man had a beautiful little 3-year-old daughter and was completely unable to enjoy life with her. He came in with moisture chamber glasses. He was on Restasis. He was using lubricant drops approximately every 5 to 10 minutes. He had a baseball cap on, dark glasses, and was sitting with his hands covering his eyes when he came in for the initial evaluation. Surprisingly, his visual acuity was 20/20 in each eye. So we put some lenses on. In the right eye, we put a diagnostic lens of 50 diopter base curve. It had central clearance, but not enough limbal clearance. This guy had a really wide horizontal visible iris diameter. And so we ended up enlarging this lens. You'll notice that that first peripheral curve, instead of being a 2.0, is a 2.3. And so we made the lens into an 18.6 lens rather than an 18.2. Left eye was roughly the same, and so we ended up with a larger than average lens in both of his eyes. I think sometimes in these graft versus host patients, a larger lens might actually work a little bit better anyway, because the conjunctiva is also really dry, and when the lid goes over the conjunctival surface, I think it must feel a little bit like sandpaper. So here's a picture of him. Now you will notice the inferior decentration that you note with a large lens, but keep in mind that we're also pulling upper and lower lids out of the way there. When the lower lid was in place, that lens moved up a bit. And, oh my goodness, where am I going? Let's go back here. Moved up a bit and actually centered pretty well. Plenty of limbal clearance here, and he was much happier. Again, here, we're moving that lower lid down, but you can just barely see the edge of the lens way out in the side here. And again, a little area of superior corneal touch, which never did erode during the 4 years that I've been following him. Now, since I initially fit him with lenses, he's undergone cataract surgery in both eyes. We refit after cataract surgery. He continues to wear a combination of moisture chamber glasses and scleral lenses as he needs to in order to maintain ocular comfort. During more humid times of year, he finds that he's just fine with the moisture chamber glasses alone. Sometimes he actually prefers to wear the scleral lenses alone, but he will utilize his interventions as he needs to in order to make himself as comfortable as he needs to be. So he's doing really well. So that concludes our case discussion. Just thought I'd go over a little bit about the fitting process as we do it here. We consider the first evaluation kind of a fact-finding mission. I want to know if the patient can tolerate application removal of scleral lenses. I want to know if the patient experiences any improvement in visual acuity or any improvement in comfort with the scleral lens in place. This is particularly useful for patients who have perhaps ocular surface disease without significant clinical signs. Sometimes patients in that category will notice significant relief with scleral lenses. At other times, it doesn't seem to make much of a difference, and I hesitate to commit them to a fitting process that's going to take several visits and a considerable amount of money if they're not going to experience a benefit. So I do like to try on diagnostic lenses rather than attempting to fit these things empirically so that the patient can kind of know what they're getting into. Once we have determined that we are going to begin the fitting process, we'll get the lenses ordered. Application and removal training takes place generally first thing in the morning, and then I will normally see the patient after about 3 or 4 hours of wear. I'm sure those of you who have fit scleral lenses realize that sometimes lenses can look really different after a couple of hours of wear compared to 15 or 20 minutes of wear. That gives me an idea as to whether or not I'm close to the fit that I need or power that I need, or if I am going to need to make some major alterations. It also gives me an idea of how well the patient is going to tolerate application removal, because they will normally have 3 hours to think about their training session and will certainly give me an earful if they didn't feel that it went well. It'll let me know if I need to schedule additional training. If everything is looking good at that first visit, I'll send them home with the lenses, see them back 1 to 2 weeks later just to make sure everything is going okay. If everything is fine at the second visit, I will release the prescription and let them go until their 6-month follow-up. Very frequently I find that I need to make slight adjustments in the lens at that first visit. So perhaps the power is off a bit. Perhaps the fitting relationship isn't exactly what I want it to be. If that's the case, I'll order replacement lenses based upon the patient's original lenses. I'll mail out the replacement lenses to the patient if they happen to be from out of town. They can return the original lenses to me, and I'll see them 1 to 3 weeks after they get the second set of lenses. I always tell patients that it's a possibility that I will not be satisfied at all with the fit of the lenses. So at the initial evaluation, at the evaluation after application and removal training, if it looks like the lens could potentially be damaging to the front surface of the eye, I will of course not dispense it, but order another lens and go from there. On occasion, if I think that a patient may have significant difficulty applying and removing the lens, I'll schedule a delivery appointment or application removal training with one of our diagnostic lenses prior to actually ordering a lens. That gives the patient an opportunity to experience firsthand what it's going to feel like to put it in and take it out. Once the fitting process is completed, I do like to follow patients about every 6 months. I found that one of the most important things about scleral lens fitting is to manage patient expectations, particularly for patients with dry eyes. They sometimes come in thinking that scleral lenses are going to completely cure the condition, but I like to stress that scleral lenses are actually additive therapy rather than substitutive therapy. So if a patient asks me if they will no longer need to use drops if they wear scleral lenses, I try to assure them that we are simply going to add scleral lenses to anything else that they may be doing, including Restasis, punctal plugs, possibly doxycycline or azicite, and that they can use scleral lenses as one more tool to achieve the comfort that they need. I tell all patients that spectacles over the lenses might be necessary in order to get the best possible vision. A lot of the patients that I fit are over the age of 40, so we can certainly nearly guarantee that they will need some sort of near correction. Monovision is certainly an option, and some lenses do in fact offer the opportunity to prescribe multifocals. I haven't gone that direction yet. Most of the patients that I fit have somewhat compromised vision, and I want them to have the clearest possible vision, and so I tend to keep them in single vision lenses and then have them use reading glasses or progressives over top of the lenses as necessary. So to point out to patients who may be coming in simply for refractive correction. Sometimes the idea of spectacles over the lenses is discouraging, but it is that way not a surprise if I tell patients that they may have to wear glasses over top of the lenses. I'm a little cautious about the maintenance of corneal health, so I am rather aggressive about telling patients that they should remove the lens, rinse it, refill it with fresh saline, and reapply after about 4 to 6 hours of wear. I describe to them the living tissue that is behind that lens. Corneal cells are like little engines, and like all other engines, they produce exhaust products, which are then deposited in the tear layer. Well, when you're not wearing a scleral lens, the tear layer gets flushed pretty regularly off the front surface of the eye. But when you are, those cellular waste products or cellular exhaust products can build up behind the lens and create a pretty toxic environment. So I am rather assertive about telling patients that they should remove the lenses and refill with fresh saline every couple of hours while they're awake. And I also reiterate to them that the fitting process is most certainly going to take several visits over the course of 6 to 8 weeks. I'm always surprised at the number of patients who think that they are going to go home with the perfect lens for them the first time out. But it is pretty normal to have to order more than one lens in order to optimize fitting relationship and visit. So in conclusion, we now have diagnostic fitting sets for a variety of scleral lens designs, and those diagnostic fitting sets are tremendously helpful in the fitting process. Manufacturing processes are becoming even more accurate, more repeatable, more customizable, even as we speak. Scleral lenses may not be for everybody, but they'll certainly allow us to delay or avoid more aggressive intervention, such as surgical intervention like tarsorrhaphy or penetrating keratoplasty. The other thing that I'm realizing that scleral lenses can do is bridge a time period. I had a patient the other day who wanted to wear a scleral lens in one eye while undergoing a penetrating keratoplasty in the other eye. His intent was to wear the lens only long enough to have the surgery and recover from the surgery and then discontinue its wear because the eye that was to be operated on was in fact his stronger eye. So that's another option. It can buy you some time for such an application. A couple of references here. This is just a selected bibliography, and it will be available on the recording of this presentation. These references are also available on the Scleral Lens Education Society website. That's one of my jobs. I'm going to try to keep that reference list up to date. If any of you publish articles on scleral lenses, I would most certainly like to hear about it. And for more information, of course, you already know about scleralens.org. Thank you very much for your membership and your interest in these devices. And that concludes my presentation. Thank you so much.
Hey, Muriel, this is Bruce Baldwin. If everybody's that was really good. If everybody's mic was made hot, I'm sure you would hear lots of applause out there from the audience. And I actually saw one person use the applause button on the left.
I saw that. Thank you very much.
So for the
Kathy.
participants, if those of you that want to stay around and ask some questions, thank you for the applause button, Kathy and Diana. Those of you who want to ask some questions, I'm not going to place anybody's mic hot. So we want to use the chat area over to the left. So if anybody has a question for Muriel, you can type your question in the chat bar, and I'm going to turn Muriel's mic back on.
Appropriate for quiet SLK. I would say if it's quiet, yes. Now, the challenge there is that these lenses do tend to decenter inferiorly just a bit, so you'd want to make sure that you've got excellent centration. This is an answer to Kevin's question. But it may keep things even quieter. And Kevin, does that answer your question? If so, thumbs up. Am I seeing you? Or type in a yes or some such thing. All right. Wonderful. And let's go on to, I think Greg had a question too. What solutions do I prefer to prescribe the patients to fill the lens with? Well, I typically use Unisol 4. I think that's pretty standard. I do have patients make sure that they don't keep that bottle any longer than a week. I prefer that they open a bottle and use the whole thing within 3 to 4 days at the longest. There are single-use vials of non-preserved saline available. I know at Amazon.com. It's made by, I believe, Medline Pharmaceuticals, and they come in about 5 ml tubes. Very handy for traveling. The patient with graft versus host disease that I discussed actually came up with that for me and shared it with me. And so I've been sharing that with patients who travel a lot.
Hey, Muriel, I've checked with my hospital, a UNC hospital, and they actually stock the 15 milliliter vials of sterile saline, and I have not yet done it, but I'm going to try to prescribe the 15 milliliter vials of saline for my next scleral patient and see if they can just get it from the pharmacy.
I think that's a great idea. I really like knowing that, you know, they're not putting saline in that's been sitting in their medicine cabinet for 3 weeks, and a 15 milliliter vial would be great, would be wonderful. And Jeff, severely non-wetting lens on a graft versus host. Oh my goodness. I would be more than happy to entertain any suggestions on this. I have found that I don't have all the answers to this one by any means, but I found that if you treat meibomian gland dysfunction pretty aggressively with either doxy, if that's tolerated, or lid compresses, lid scrubs, that you can reduce the amount of oil on the front surface of the lens. Sometimes, though, the lenses are just they're gonna get really coated because there is not much fluid on the front surface of a patient with graft versus host disease. Sometimes just supplementing the tear film with lubricants. As I mentioned earlier, this is an additive therapy, so if patients need to use lubricants over top of the lens in order to thin out or dilute lipid in the tear film, that may be helpful. So Jeff, hopefully that answered your question just a bit. And
2 quick comments on severely non-wetting lenses. If you go to the SLS website, in the forum section, there are a lot of people talking about that problem. It's a big problem, and I don't know that anyone has ever had a really good solution to it. I can tell you one patient I had recently with a severely non-wetting lens, and I looked at it under the microscope, and it had a lot of micro scratches on it. I polished it with my polishing machine that I used to polish rigid lenses with, and it's been wetting really, really good since then.
Bruce, thank you very much. That is absolutely true. As we all know, any deposit or compromise on the front surface of a lens is going to increase the stickiness of that lens, if you will. And boy, it seems like on these Sclerals, since they are such highly oxygen permeable materials, once you get a little area that's not wetting, it just spreads fast, unfortunately. So this is probably a very good topic for our discussion forum on the website. So if anybody's interested in starting such a thread, it'd be interesting to see what everybody else is doing here. All right. And back to Kevin. Any difficulties getting enough fluorescein under the lens? Thank you very much for bringing that up. I will normally, when I'm fitting the lens the first time around, douse the front surface of the eye with fluorescein and then apply the lens with clear saline over that. And the reason I do that is that I don't like orange sleeves. It seems like I'm always dripping down to my elbows when I'm putting lenses on. But initially, I used to fill the bowl of the lens with saline and then put a fluorescein or dip a fluorescein strip into that, and didn't have any trouble getting fluorescein back behind the lens that way. Now, I use fluorescein in subsequent follow-ups to determine whether or not there's any tear exchange underneath the lens. So I'll put a dab of fluorescein on the lens after I've taken a look at it. Then I'll go ahead and do my spherocylindrical overrefraction. And 99 times out of 100, I will see plenty of fluorescein back behind that lens when I'm done with the overrefraction. And that just lets me know that there's at least some tear exchange, even if there's not a lot, not as much as in a rigid gas perm, or yeah, not as much as in a rigid lens. And I'm reading a note from Lynette that says that I can prescribe 0.9% inhalation saline in 3, 5, or 10 milliliters, or prescribe balanced BSS. Expensive unless it's covered by insurance. Yeah, Lynette, you're absolutely right. Thank you so much for letting us know that. I do like the idea of smaller volumes as opposed to Unisol 4, so can see myself moving towards some of those smaller possibilities as time goes on here. Lynette, are you the Lynette Johns that I know from Boston? I'm assuming you are. Yeah, and Greg Denier notes that lenses that are plasma treated are also somewhat less likely to deposit. Azocite, oh yes, Azocite is our friend too. Thank you, Jason. And Jeff asks if we use plasma or non-plasma and Boston Original. I'm tending to use OptiFree GP for a soaking solution for most of these. I order all of my lenses plasma treated. It doesn't last forever, but I think it certainly helps get the patient used to that. And Kathy says that she fit a lens on a patient with a fornix reconstruction, a chemical burn. Air bubbles are unavoidable in this situation because of an irregular surface of the conj. They basically just cover the conj and stay from the cornea. You know, yes, you are going to get some air bubbles once in a while, as long as that air bubble is mobile and as long as you're not getting drying in a particular area under the lens. Yeah, in some cases like this where the conjunctiva is just so irregular, you are going to get some bubbles under the lens. I've had a couple patients who have had Gunderson flaps, which is basically taking conjunctiva and pulling it up over a persistent corneal defect. And they too are going to bubble. Sometimes if you can get a customized peripheral curve, it's useful. I think that some of the companies that manufacture scleral lenses are actually able to do that for you. And Kathy asks, is CVS sterile preservative-free saline okay? I don't have a CVS in Rochester. Is anybody else familiar with that particular product? Bruce?
I'm not familiar with that product.
Okay, if it's a sterile preservative-free saline, my guess is that it's very similar to Unisol, and that should be fine. I just like to stay away from any preservatives. I don't want to place preservatives in the reservoir and then keep that reservoir in contact with a potentially fragile cornea. And Jeff asks, is filling the chamber with non-preserved artificial tears instead of saline off-label? Well, technically, I suppose it would be off-label, Jeff. This brings up an interesting, or kind of a little clue. If a patient's having a really difficult time applying the lens without dumping half the saline out, you can kind of use Celluvisc as training wheels. It's non-preserved. I think the osmolality is probably a little bit different than what we might want on a cornea long term, but on occasion, if a patient really needs some help getting that lens on, for instance, if they've got a tremor or something and they need not to spill the saline on the way up to their eye, Celluvisc works pretty well. Artificial tears would probably work as well. The challenge with artificial tears is that they all have wetting agents which could potentially deposit front surface of the eye. Or, I'm sorry, the front or back surface of the lens. And Lynette has chimed in. Thank you, Lynette. CVS preservative-free is a good equivalent to Unisol 4. So thanks to Lynette, who was familiar with that product.
Okay, this is Bruce. I'm going to call for questions one more time. If we don't have another question, I'll come back with one final comment.
Well, I just want to thank everybody for being a part of this discussion. Fitting scleral lenses has been so much fun for me during the last 4 years, and I am more than delighted to have colleagues all over the country to whom I can refer patients if necessary. When I first started fitting sclerals about 4 years ago, I would present at meetings and people would look at me like I had 3 heads. Apparently, those of you who are participating in the meeting tonight are just as enthused about them as I am. So thank you very much.
Muriel, Marcy asked a very good question. See if you can check that one out.
Let's see, Marcy down at the bottom here. Marcy, yes, Marcy, I think I just met the gentleman that you work with at the Mayo meeting, and you were on my list of people to call, so very nice to have you here. What's my experience with putting a soft lens underneath the scleral for patients who have raised conjunctival issues? I have not had experience with that. The lenses seem to be, the lenses that I'm using are 18.2, and so they're about 16 millimeters out by the time they start to land. But on a cornea scleral or a smaller scleral design, that might really be a great idea. Marcy, have you had any experience with that, or has anybody had any experience with that particular idea?
Hey, Muriel, this is Bruce again. I have now fit 3 patients with piggyback scleral lenses, and I use a plain old silicone hydrogel, a soft lens, and in those 3 patients, it's been a really big problem solver. Not so much with fit, but lenses that look very good to me, but the patients have this nagging problem with the lens being a little bit uncomfortable. And I 2 of those 3 are still wearing piggyback lenses, one in both eyes every day and one of them in one eye every day, and they're working marvelously. And I've got some photographs maybe I can post on the SLS website soon.
That would be marvelous. You know, that sounds like a great idea. When I was in England, one of the patients that participated in the workshop that Dr. Pullum sponsored was a patient with severe keratoconus who had 2 sets of scleral lenses. One set fit really close. I mean, I guess technically from my definition it wouldn't even be considered a scleral lens because it was actually bearing on the surface of the cornea. And when she wore those lenses, she would wear a single-use hydrogel lens underneath it to protect the apex of the cone from any mechanical damage with the scleral lens. She had another set of scleral lenses that actually vaulted the corneal apex completely and fit more like a traditional scleral, but she didn't see as well with that set. So she discovered that if she wore the soft lens underneath the scleral and got just a little bit of compression of that cone, it reduced a little bit of the aberration that she noted. So I've heard of it, I just haven't used it yet, but Marcy, thank you very much for bringing it up, and Bruce, thank you for reiterating. I'm going to have to give that one a try.
And Miguel has a question.
Okay. Any hands-on workshops you can recommend? Oh, Bruce, are there any? Are you aware of any workshops that the Scleral Education Society is sponsoring in the next couple of months here? I know it's a pretty active time for meetings. Now,
Mindy just did one at the East-West Conference. I'm doing one in Asheville in November. I don't know if there's any spots left in that one. And there's always a scleral lens workshop at the Specialty Lens Conference in Las Vegas in January. And any other workshop notifications we get, they're posted on the courses/workshop section of the SLS website.
Yes, thank you. I know that Jason has presented a number of workshops, as has Chris Sint. So look out for those, and we will keep the website updated, Miguel, so that you can hopefully find a workshop in your area. And Jason also chimes in and says that he has a couple of 14 to 15 millimeter lenses with piggybacks. And Greg says it can work very well. Well, thank you very much, all. I've learned a lot tonight. Thank you. Kathy asks, what size corneal scleral lenses do you piggyback with? My guess is that you're piggybacking with a smaller lens than an 18, like 14 to 15 millimeter would probably be a successful lens to piggyback with.
Those three, this is Bruce again, those three patients I mentioned with the piggybacks, they all are 18.2 millimeter lenses, and I think the problem they had with comfort had to do with maybe some lens touch somewhere near the limbal area, and that 14 or 14.2 millimeter soft lens was able to cover that area.
Sure, that makes sense. Kathy asks, or states, patients see better with some apical bearing, but since the CLEX study, I've tried to avoid it. Do you think some apical touch is okay? I've discovered with most of my cone patients that they see quite well even if I don't compress the apex of the cone, so I try to avoid it, but that is certainly a topic that could easily be open to quite a bit of discussion, and that might be another very interesting thread to start on the discussion board on the website. I try to avoid it personally, but I can certainly see an argument for just a bit of touch. Since the scleral lenses don't move as much as corneal lenses, I don't think you'd get the scrubbing action that you can get with some corneal lenses over the apex of the cone. So maybe okay. And Jason chimes in answer to Miguel's question, mini scleral workshop at the Academy meeting and at the Global Specialty Lens Symposium, and there is a how-to contact lens meeting in San Diego coming up in the not too terribly distant future. Steve Burns is also doing one at Academy next month. So Dave Block from the Netherlands asks, could you please tell for another time the basic diameter of choice and the first started radius? The Jupiter lenses are the lenses that were designed by Dr. Rob Brees, who passed away roughly a year ago, much too soon in all of our estimations. The standard lens that I use from the Jupiter series is the 18.2 millimeter series. That lens has an 8.2 millimeter base curve. The first peripheral curve is a 0.4 millimeters flatter than the base curve, and the run on that is 2 millimeters. Then the final three curves are 9.0 millimeters for 1.0, 12.25 for 1.5, and 14.5 for 1.0. And again, these are endlessly modifiable. And Kathy states, I have a patient with an Ahmed valve that I'm having a Trueform make a notch in for fitting. Are most fitters doing the notch themselves with their own modification tool, or are they having the labs do it? Boy, Kathy, if I had a patient spend hundreds of dollars on a lens, I would certainly send it back to the lab to do it. I believe that most of the labs will, in fact, make a notch. I know that Chris Sint has talked about having her lab make a notch. Is there anybody brave out there who makes the notches themselves, or would they just send it off to the lab? By the way, the notch is a great idea for getting around a valve or a bleb in a patient with after glaucoma surgery. And thank you very much, Jeff, for chiming in. And Dave from the Netherlands is again asking, why should I use scleral lenses in order to soft keratoconic lenses, in order to fit soft keratoconic lenses? I'm afraid I don't quite understand the question. Could you restate that perhaps, Dave? Okay, Kathy Whitman asks, this was asked at GSLS, there was some discussion about hand-painted sclerals. Anybody know if somebody was able to figure out a way to do it? Is anybody doing it? I came really close to doing it on a patient a couple of years ago. He came into Mayo wanting his right eye removed. Given the fact that he didn't have an APD and had 2100 vision in his right eye, we decided that we didn't want to take it out. So we were going to try a scleral lens, and we actually got all the measurements done and everything, and got pictures taken, and he was lost to follow-up, unfortunately. I was kind of looking forward to that one, but we were going to send the lens off to Crystal Reflections to do some painting for us. I know that there's a number of companies that will do some custom painting. The concern with painting a scleral lens, yeah, exactly. Greg says it can only be done on PMMA material, not very breathable. And so I wasn't particularly concerned about my patient because his cornea was 100% vascularized, and I knew that, you know, his cornea would get plenty of oxygen. It probably had too much. But I would be concerned about lack of oxygen under PMMA lenses in a patient without extensive vascularization. Oh,
Muriel, let's
thank
take
you.
this one last question. Dave Block rephrased his question, and it's a very, very good one.
It is. What are the advantages of scleral lenses when you compare them with soft keratoconic lenses? That's an excellent question, Dave. The optics might be just a little bit crisper with a scleral lens, but a soft keratoconic lens could certainly be an option as well. Anybody else want to weigh in on what you do first, a soft keratoconic lens or a scleral lens? I have very little experience with the soft keratoconic lenses. I have good luck with the sclerals, I guess, and so that's the one I reach for first. But would certainly be interested in hearing what other folks had to say about the soft keratoconus lenses. Bruce, have you had any experience?
Yeah, I have a couple of soft keratoconus fitting sets, and now I'm starting to try to fit more people with them. I think they sometimes work really good for the more moderate and sometimes moderate to severe keratoconus, but for a lot of these other patients that we see so often, the corneal transplants gone bad and graft versus host disease and so forth, I want as much oxygenated tears under the lens as possible, and I don't know, but I would think the visual acuity would be better with sclerals. But I know over in Europe there are a lot more of the soft keratoconic type lenses being fit.
Yeah, it'll be interesting to see how those move to the United States. My guess is that they will, but they haven't as of yet. Miguel has a quick question. Bruce, which is the meeting in November? The American Academy of Optometry is meeting in San Francisco in November. So thanks again to everybody who participated. I look forward to seeing some of you, hopefully, at the Academy or at the Global Specialty Lens Symposium coming up. And keep fitting those sclerals.
Okay, thanks again, Muriel. And one last note before we sign off. Hopefully we've recorded everything we've done tonight, and we'll post a link to the recording that you can review or send to your friends and watch this at your leisure. So on behalf of the Scleral Lens Education Society, good night, and we hope to see you at another webinar very soon. Good night.